This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you. Today we're going to do another Nightmare Series case study. I know we kind of took a hiatus from our vasopressor podcast series. We will jump back into that on the next podcast, and I'll jump into inodilators, and then we'll do a podcast specifically on vasopressin, and then we'll finish it up with the pure pressors and discuss neosynephrine and the kind of the new science behind that. But like I said, today we're going to do a Nightmare Series case, and a lot of times on these podcasts, I get inspired by things. I get inspired by either content that I read in journals or ways of treating patients. So, it really forces me to stay on top of the pathophysiology and understanding the disease process. And I think we all learn from applying cases that we've had or seen. And so I think it's a great model to continue. So today's nightmare case is going to be a pulmonary embolus. And these are cases that can be, or calls that can be really stressful. You have a very, very sick patient, and either they start off as just a very stable patient, maybe with a DVT, or you get on scene and you have a patient that's extremely sick. So I think with a pulmonary embolus, the big thing we have to understand, and I think this is probably a disease process that we don't understand fully as far as the pre-hospital provider, general paramedics, nurses. Do we fully understand all the dynamics involved in a pulmonary embolus when it actually, when you have a sentinel event, when you have an event where a large clot lodges in that pulmonary artery? And, I know for me, if I look back 5-10 years ago, I probably didn't have a in-depth understanding of everything that goes on in this presentation, and it's pretty bad. So what we'll do is we're going to start off with the case. I'll talk about the case real quick, and then we're going to go into the pathophysiology like normal. The meat of the podcast will obviously be that, and we'll talk about different treatments, the different theories, kind of what the top MDs and intensivists are doing related to pulmonary embolus. And again, the whole purpose of the FlightBridgeED podcast is to bring the highest level ICU critical care concepts that these intensivists, these research MDs are doing around the world. And so my whole goal is to progress the pre-hospital environment by bringing those concepts and spreading the word as fast as possible. It's really important to me. I think it's terrible that information takes 5 to 10 years to trickle down to these smaller communities, these rural areas. And so that's my whole focus, is to try to get this information out. Okay, so the case is a 41-year-old male patient. He is at home. He starts complaining of lower leg pain. He starts seeing some redness in his calf, and it radiates up into his knee, kind of the back of the knee area. Talks to his wife about it. They go into their primary physician, and they do a CT scan. They do an ultrasound. He's got real minimal pulses in that foot, and they send him over to do a CT scan just to make sure, because he says that he's been complaining of some mild shortness of breath. He's kind of more tachypnic than normal, but still been working outside, working on the farm, jumping on the tractor, all that stuff, and he but just doesn't feel right. So he goes over to the CT, and the CT tech comes in and says, the doctor wants you to be transported to a facility. As the patient's sitting there talking to his wife, the physician comes by and explains that he has a couple small clots that have formed in his lung, and they're kind of worried about that. They want him transported so they can take care of it at a definitive facility. So you're called as a flight crew, and you arrive on scene. You find this male patient. He's approximately 100 kilos. He looks a little bit overweight. He's about 5'8", and he's tachypnic. He's breathing about 24 times a minute. He does have reddening in that right leg, that calf area. He has a very diminished pulse. Just swelling in that leg. You put him on the monitor. You do a 12 lead on him, and you don't see any ST elevation. We'll just put it there. At this point, you put him on some oxygen. You put him on your monitor, and you put them on your aircraft cot. You're flying on an EC-1 35, we'll say, and you take off for the receiving facility. At this point, you have about a 40-minute flight. Immediate in the flight, you notice the patient's becoming more agitated, and you notice a drop in the blood pressure. Normal blood pressure for him was about 140 systolic. When you picked him up from the facility, it was about 148/80, and he was a little bit tachycardic at about 120. You notice a change in his vitals, and now his blood pressure is 96/60. He's even more tachycardic. He's got a rate of about 140, and his breathing is now pretty rapid. It's about 28 to 30 times a minute. So we're going to stop there, and we're going to talk about the pathophysiology. The first thing we have to remember with a pulmonary embolus, especially when you have a clot that lodges in that pulmonary artery, is you have a profound dead space ventilation. And so we've talked about this many, many times on other podcasts, specifically with ventilator management and dead space ventilation. And remember, dead space ventilation is essentially blood that is not catching up with gas exchange. So you have some type of issue where that deoxygenated blood is not able to travel through the lungs to be oxygenated. And the most profound dead space ventilation is obviously a pulmonary emboli. So in this setting, we have other issues that happen because of that. The first thing we have to remember, and we talked about this in our podcast on dopamine, getting rid of dopamine in the pre-hospital environment and adding levo. If you haven't heard of that podcast, go on there and check it out. But I go into a very in-depth talk on unstressed volume versus stressed volume in our peripheral vascular resistance and the volume that's in our venous system. Remember, there's a huge amount of volume in that venous system. Well, remember, the whole right side of your heart, the whole point of that is preload. So you have your right atrium. We talked about the patho there, where you have your tricuspid valve. We talked about the pathophysiology as far as how blood flows into your right ventricle. The majority of that is done via gravity. 80% of your preload is based on gravity, just that tricuspid valve remaining open. The last 20% is that atrial kick. The big thing about your right ventricle that's pretty cool is it gets perfused during both the systolic phase and the diastolic phase, whereas your left ventricle only gets perfused during diastole. Some other things we have to remember and understand about our right ventricle is our right ventricular pressures, systolic-wise, are usually around 25 millimeters of mercury. And that's the exact same pressure as your systolic range of your pulmonary artery. So your pulmonary artery pressure and your systolic right ventricular pressure are usually going to be equal. And that's really important. When you look at your systolic left ventricular pressures, which is our normal blood pressure, we know that those numbers are around 120, 130, 140, right? Those are our systolic blood pressure numbers. So you can see right there your right ventricular pressures and your left ventricular pressures. There's a huge difference between the two. And that's an important concept to understand when you're talking about a pulmonary emboli, because right ventricular pressures, or I should say the right ventricle in and of itself, cannot handle any sudden increase in pressures. Even a sudden increase of 10 millimeters of mercury in that pulmonary artery and that right ventricle is going to cause a massive, massive problem. So when you have this issue, when that clot actually lodges in that pulmonary artery, you have a massive spike in your pulmonary vascular resistance. Now this causes a huge, huge problem, because you have this huge, massive rise in pulmonary vascular resistance that translates to higher pulmonary artery pressures, which translates to a higher right ventricular pressure. And so that sudden spike immediately causes a right ventricular systolic and diastolic dysfunction. So what does that mean? Well, if you don't have a good right ventricle, if you don't have a good right ventricle, then essentially you have no preload. So something you have to remember is that everything that comes into the right side affects what goes to the left side. If you have a collapse of that right ventricle, then you're going to have essentially a collapse of your afterload. So any massive increase in pressure is going to cause an infarct or essentially just as simple as ischemia to that right ventricle. Because remember, like I said, you have perfusion to that right ventricle during both systolic and diastolic phases. So if we don't have any preload, if we don't have a right ventricle that is effectively pumping, we have this high amount of pulmonary vascular resistance that's going to translate to a very poor afterload. This is called the right ventricular spiral of death. We have to do whatever we can to somehow optimize both our preload and our afterload, as well as reduce our pulmonary artery pressure. So the goal is going to be to attempt to improve our preload, but not increase our pulmonary vascular resistance. We don't want any more increase in that pulmonary vascular resistance. So we want to optimize that preload somehow. We want to optimize that preload so it optimizes the afterload. So we want our systemic vascular resistance to actually improve. So we're going to talk about kind of how we do that. A secondary issue is now that you have this right ventricle that's under all this pressure, if you were able to look at this via an echo, you would actually see the septum that separates the right and left ventricles. You'd actually see those deviate. You'll see that septum deviate and push into the left ventricle. Well, what is that doing? Well, now what you have is you have a right ventricle that's under so much pressure that it's kind of acting as a dilated cardiomyopathy. And you also have that effect, that transient effect of that septum now deviating and pushing into the left ventricle. And that's going to act as more of a restrictive cardiomyopathy on that left side, just like you would see with a restrictive left ventricular dysfunction. So now you have an ejection fraction. You have the amount of blood that's able to be ejected out of that left ventricle be significantly reduced. So it's really important to understand that this pulmonary emboli is causing profound issues hemodynamically. And we have to do some things to attempt to, number one, decrease that pulmonary vascular resistance. Number two, perfuse the right ventricle to lower those right ventricular pressures. And we don't want to cause any further harm, right? We don't want to cause any right ventricular ischemia. The other issue you're coming down to is if you're losing your preload and you're losing your afterload, you have this high amount of pulmonary vascular resistance. You're obviously becoming hypoxic, right? These patients become tachypnic because this hypoxia is starting. Remember, that is our first sign of any sympathetic response or shock, is our body's going to attempt to increase our respiratory rate and our heart rate. As you saw in the case, his heart rate has gone up significantly. He's very tachy. So you have another phenomenon. So you have a right ventricle now that's dilated. It's under an excessive amount of pressures. You have that pulmonary artery that's under a huge amount of pressure. You have a septum that's now deviated into the left ventricle. That's causing more of a restrictive cardiomyopathy over there. That's not allowing blood to be ejected out of that left ventricle, right? So your systemic vascular resistance is in the toilet. You don't have good afterload, and you have obviously a huge issue with consumption, right? You always have to think about oxygenation or blood flow as, are we meeting the demand? We can deliver oxygen in a huge amounts in normal homeostasis. We deliver approximately 1,000 mils a minute of oxygen, and we use a really tiny portion of that. So we have a huge amount of reserves. I mean, most often in normal homeostasis, you're just utilizing the plasma stores for normal body processes. The rest of the oxygen that's stored on our hemoglobin is just utilized for those situations where we have a higher demand. Well, in this situation, we have a huge demand, and we're obviously not meeting that demand. So this is where you kind of, this comes into an issue of dealing with this airway, and how are we going to meet that? We have a patient that's moving into profound shock. We have a patient that has that pulmonary vascular resistance that's through the roof, and this hypoxia that's starting. Well, what happens to our lungs when we become hypoxic? Well, that causes a pulmonary vasoconstriction. So you could see that this is a big circle, that's compounding on itself. The other thing that they would want to do, and something that is an added issue here, is that we have not only a clot that has caused all the issues that I've just laid out, but when that clot actually lodges in that pulmonary artery, what does our body do to any type of foreign invader? And we see this in all types of disease processes. We see this in trauma. We see this in everything. Your body is going to attempt to attack it. And we have different levels of processes that attempts to attack issues or foreign invaders. And this is no different. So when that clot actually lodges in that pulmonary artery, it actually releases, or our body releases, all these pro-inflammatory mediators. And that actually inhibits normal functions and normal vasodilation. So the vasodilation that we would want in our lungs, in our small little airways, is now being attacked. It's being inhibited. So a lot of times what they'll do in the hospital setting, and this is more of a research thing, and we talk about this a lot in critical care, we talk about this in neonates and stuff like that, is they're going to give nitric oxide. And nitric oxide is a normal component that's found in our lungs. It's a profound vasodilator, and our body utilizes it for just that reason. So they'll actually use that in real severe ARDS patients to cause pulmonary vasodilation. They'll use it for kids. They'll use it for these neonates that have major lung issues that need that pulmonary vasodilation. And so they're starting to use nitric oxide for that same reason. Because of these pro-inflammatory mediators attacking and inhibiting that vasodilation, you also have that huge amount of pulmonary vascular resistance. You have the pulmonary vasoconstriction because of the hypoxia. So that nitric oxide, to me, is a great tool. Now, obviously, in the pre-hospital environment, we don't have that option. So how are we going to deal with this patient? You have this patient in front of you, you're flying along, you're 30, 40 minutes out, and you have a patient that's collapsing. So let's talk about first the 12 lead. How can you truly identify that this is a pulmonary embolus? Well, you can actually do a 12 lead, and this crew did a 12 lead, and they looked at it, but they looked at it from the perspective of, is this patient having an MI? And the patient wasn't having an MI. But you have to understand that a pulmonary embolus in about 7 to 10% of the patients will present on a 12 lead, and your 12 lead is going to be diagnostic. And I say it's diagnostic anywhere from 7 to 10% of the time. So you're not going to always have this. But what you'll have is something called S1, Q3, T3. So you do your 12 lead, you're going to look in lead 1, and you're going to have a big S wave. All right, so you're not going to have any R wave in lead 1. In lead 3, you're going to have a pathologic Q wave, right? So remember, a pathologic Q wave is going to be greater than 0.04 seconds in width. It's going to be wide, or it's greater than 1/3 of the R length. So it's either long or it's wide. And then you're also going to have an inverted T wave. So S1, Q3, T3 is a diagnostic tool that you can use in the pre-hospital environment by looking at your 12 lead to diagnose a pulmonary emboli. Now, obviously, with this patient, he had a big DVT that was confirmed. So, that's one of those things that's pretty obvious. Again, this 12 lead tool that I just laid out, it's diagnostic 7 to 10% of the time. So don't always count on that. It's just something to be able to use as differential diagnosis, to use in your charting, and just another kind of tool that you can throw in your tool bag. So what about airway management? The big thing with airway management when you talk about a pulmonary emboli is you really, really want to caution intubation. I mean, this is one of those things that you have to understand what you're doing. You have a patient that's in profound hemodynamic shock. You have a patient that has a very poor preload. They have a right ventricle now that cannot function. You have a pulmonary artery that has high pressures. That right ventricle has high pressures. You have that pulmonary vascular resistance that's actually through the roof. And you have pulmonary vasoconstriction because of the hypoxia. If you think about now a patient that's in that profound shock state, what are you going to do if you give induction agents that we use for RSI? Now, there's obviously induction agents that we can use that are better than others. And there may be a time where you're going to have to intubate a patient, but you need to really, really be cautious and maybe take some steps prior in the attempt to alleviate any adverse effects from these medications we're going to use, such as etomidate, such as Versed, things that are going to cause a vasodilation. I guess the argument or the question is, do you start a pressor even if they have a systolic of, let's say, 100, 110? Maybe they haven't progressed to hemodynamic collapse at that point, but you see that their airway is going downhill. Do you try to treat ahead of time? Again, from my perspective as the educator and owner of FlightBridgeED, I'm just laying out different options. I'm not telling you to practice outside your protocols. I'm not telling you to do anything of the sort. But I want you to learn to critically think. I want all of us to critically think. And I think it's important to be able to look at a patient like this and understand the pathophysiology and say, if I give this patient Versed, if I give this patient etomidate and they're already hemodynamically kind of borderline, or, even this patient with a systolic of 90, what's going to happen when I give that medication? So for me, if I were forced to do this, I would automatically go with ketamine and potentially, give a small aliquot of fentanyl prior. And I would consider, if we had a protocol for that, I would consider maybe a push dose pressor, right? We don't have a protocol for that, but I think a push dose pressor in this situation, maybe a quick shot of epi or a quick shot of neosynephrine, just like our podcast on RSI, and maybe push dose pressors in that setting, may be worth looking at in something like this. But obviously we don't have that protocol, just something to think about. The other aspect here is, remember, when we breathe via a negative pressure, right? We have a negative pressure in our chest, and that's an important concept to understand, not only in ventilator management, but in this setting. Now we're going to actually take somebody's airway away, and we're going to deliver a positive pressure breath, right? We deliver positive pressure either with our BVM or with our ventilator. And so this is going to actually increase pulmonary vascular resistance. We already have a pulmonary vascular resistance that's through the roof. So we have to, again, be careful with what we do. So do we use low volumes? Do we use normal tidal volumes? Do we use high tidal volumes? I think the argument here is, you don't want to use high tidal volumes. You don't want to use that hypotensive approach that I laid out just because they're hemodynamically unstable, because again, if you do that, that's going to translate to greater pulmonary vascular resistance and other issues. So the other thing is lower recruitment issues with real tiny tidal volumes. So I think using maybe a lung protective strategy, anywhere from 4 to 6 mils per kilo, maybe a little higher rate in this type of patient, and then maybe using PEEP in a very modest way, right? You don't want to cause any further issues in the pulmonary vascular resistance. So you can see that there's a lot of issues that you got to consider before taking somebody's airway in this situation. You really, really have to be careful. So if you were going to select a medication, again, maybe give a small dose of fentanyl. Remember, it's not going to have a drop in that blood pressure. It's going to be very good in low doses, no catecholamine release. Give a good dose of ketamine, again, very hemodynamically stable. It's going to give that bronchodilator type effect, that beta-2 stimulation, which is kind of what we want. And then prior to that, consider starting a pressor, right? This is one of those things where you and your partner are going to be taxed to the max, and you're going to have to make good decisions. So, this may be something that I would try to do. I would try to maybe use passive oxygenation techniques, put them on a nasal cannula at 15 liters per minute, put them on a non-rebreather at 15 liters per minute, continue with that passive oxygenation, start a pressor. Look at Levophed and start a low-dose Levophed and start that on board. I'm going to continue discussing the vasopressor aspect of it here in a second, but start that vasopressor early. Number one, to try to add to the whole preload aspect. Remember, Levophed is going to be very good at lower doses in giving a little boost in preload. What about giving fluid? Here's the thing on fluid. If you give too much fluid, you're going to cause it even more of an issue with that right ventricle. That right ventricle, again, is under an enormous amount of pressure. So it's not going to be able to handle that huge amount of volume. So, reading the different studies I've read and the different protocols out there, they say to be cautious when you give fluid. So I'd probably limit that to maybe 250 cc bolus, and then I'd go straight into a pressor like Levophed. Remember, Levophed has great beta-1 effects, and it's gonna really be good on both preload and afterload, and that's exactly what you want. It's not going to have any adverse effects on that pulmonary vascular resistance either. So at this point, you got to make that decision. You've got that passive oxygenation going on. You've potentially started that vasopressor to optimize that cardiac output while you give these induction agents. And then you need to pick a medication to paralyze them. So again, just like the last podcast on passive oxygenation, I laid out a study that's excellent that really, I think, for me, solidified what paralytic I'm going to start using based on a choice. If I have a choice between Sux and Rock, I'm going to go with Rock, just because of the aspects of desaturation and oxygenation consumption. With the succinylcholine and the aspects of the fasciculations and the muscle firing, you're going to burn through a lot of oxygen stores. And in this patient, to me, they don't have that. They don't have that ability. They can't really sacrifice that. You want to stay away from a medication, in my opinion, that's going to, add to the issue. So again, I'm going to probably go with Rock on that. Okay, so when we continue with our Levophed, remember, Levophed is going to be really, really good in this situation. You're going to have great preload and afterload effects. And that's what you, again, want to do. You're trying to improve preload. You're trying to improve your systemic vascular resistance. You're trying to give that SVR a little bit of a boost, because essentially we still got to be able to perfuse our brain. Remember, if MAP pressures drop much below 50, you have very poor perfusion to your brain. That's where you start having brain ischemia. Same thing goes with our kidneys. If we drop below 65 on our MAP on our kidneys, they kind of stop perfusing. So we have to make sure that we attempt to perfuse those types of organs that are so essential. And then we have other options, right? We have our Levophed on board. We have a patient that's hemodynamic collapse. What can we give them that's going to aid in contractility? What's going to give them great contractility? And that's dobutamine. This is one of those medications that is excellent when you have the need for increased contractility. You want that inotropy. You don't necessarily want a huge chronotropic effect. And you want some vasodilation as well. And that's exactly what this dobutamine is going to do. It's going to give you that vasodilation. You're going to get that pulmonary vascular resistance to kind of come down. It's going to optimize that contractility. And it's going to kind of be a great augmentation medication to go along with that Levophed. What about neosynephrine? Well, the whole thing with neosynephrine, and the things that I keep reading and hearing, is a lot of these top intensivists around the world are completely getting away from neosynephrine. And I know, I've talked to different nurses out there, different people that use neo in the cardiac ICUs, in the medical ICUs, and I think there's probably still a place for it. But the big aspect with neosynephrine you have to remember is it's such a potent alpha-1 agonist that oftentimes you have this false blood pressure. And the big negative thing here with neo is it's going to increase your pulmonary vascular resistance significantly. And that's something we just can't have in this type of patient. And then you have this huge squeeze, but do you have blood flow? Do you have good flow, right? We have to remember that we have a vessel. We have to have good flow. We can't squeeze them down so much that they don't flow this oxygen-rich blood that we need. So neo would not be a good choice in this setting. What about vasopressin? Vasopressin is one of those medications that is excellent. It's gaining popularity. I think a lot of these intensivists are going with vasopressin as their number 2 pressor, Levophed being number 1, vasopressin number 2. I know I've already, in my practice, flying as a flight paramedic, I've already made the decision. If Levophed isn't getting the job done, based on our protocols and our methods, we have the freedom to go to vasopressin, and I'm going to go and I'm going to try it. One of the things with vasopressin you have to understand, it's very safe. You have a medication that is going to only pick up and be utilized by those vasopressin receptors if it's needed. It's got great vasoconstriction effects. It has no effect on pulmonary vascular resistance, but it's got excellent effects on that systemic vascular resistance. So that's exactly what we're looking for. A great way to mix it, there's kind of multiple ways. I think the easiest that I've found to mix it is, get a 20 unit vial, mix that in 100 mils of either normal saline or D5W, and then your dose range is going to be 0.01 to 0.04 units a minute. So that's another option you can go with. So I think either one, again, Levophed, everybody's getting pretty comfortable with Levophed, but if you have vasopressin, you may try that. And then again, optimizing that with dobutamine. But remember, you want to make sure that Levophed is on board, that you have some type of a pressure. You don't want to just give dobutamine first out. You don't want that profound vasodilation that you're going to get initially with dobutamine. Because remember, with dobutamine, we normally want to fill the tank. We want to make sure that tank is full before we hang dobutamine. And in this situation, we really don't have that luxury. Remember, the right ventricle cannot handle that huge amount of volume. We don't want to cause any more issues with ischemia, with transient pressures that are going to cause more pulmonary vascular resistance or pulmonary vasoconstriction. We just can't afford that with this patient. So as you can see, there's a lot of things to consider when we look at treating a patient with pulmonary emboli. I just really want to caution you as far as the airway goes. This is the one area I think that can really get you into trouble. We have to really, really think about what's going on with the patient. Think about what you're going to do induction-wise, what medications you're going to use, and how that's going to affect your patient, because you pick the wrong medication, you may dump their pressure and you may cause them to arrest, and that's not something we want. So in this situation, maybe less is better, right? If you can oxygenate them with passive oxygenation techniques, even if you had to bag them, what is going to be the better option? But I think we have good medications out there. We have good medications in the critical care environment. I think ketamine, like I said, is a great medication for this patient, where you could give a good dose of ketamine. You're not going to have that profound hemodynamic collapse. Then again, pick your paralytic based on, read on the different studies, listen to my podcast, listen to other podcasts, see what's out there, and, to kind of do your due diligence as far as that goes. So that's all I have for this podcast. I hope you enjoyed it. There's a lot of good information. I'll do a blog post on this. It may be about a week or so. We'll see. I've got a lot going on right now as far as things that are coming due and different projects, but I'll try to get a blog post out on the pathophysiology related to this podcast and the treatment. Again, if you have any cool cases, please email me. I keep getting emails every day, and I love it. And I'd love to hear about your calls, your flights, anything like that. So until next time, I hope everybody has a great spring break if you haven't already had it. And we'll talk to you on the next podcast.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.